Good evening, everyone. My name is Robert Hall. I am now the chairman of Project Elect, Enthusiastic Leaders Engaging in Changing Times. And as we promised from the last few weeks, we're back again to continue to share the information on COVID conversations. We know it is plaguing not only our nation, but our states, our communities, and even here local. And everybody is feeling the effects on it. So riding a shotgun with me today is none other than our co-partner, Dr. Vernon Rayford. We know Dr. Vernon Rayford is with internal medicine, medical doctor here in Tupelo that has been with us from the get-go. We're proud to have him back with new information. But we have a newcomer today. We're very happy to meet you. Let me get this right.
Yes.
Dr. Lisa Thomas Messado.
That's correct.
Wow, I did it. And you are a pediatric specialist.
I am. I'm
Right.
a pediatric intensivist.
Wow. So now you're going to have to explain that last word, intensivist.
Sure.
Give me a little bit about your background.
So I'm Jamaican.
Okay.
I did med school in Jamaica. And then I did my residency in pediatrics in Michigan. And then I did my pediatric critical care fellowship in Miami. So pediatric critical care is taking care of pediatric patients, so 0 to 18 years of age, with those patients who have critical illness. Critical being considered anything that's going to cause failure of the major organ systems, so failure of the brain, the heart, the lungs, the liver, the kidneys. And usually those patients are taken care of in the pediatric ICU because their illness is deemed life-threatening.
Okay, wow. That's a whole lot. So this is going to be interesting. Way I think we'll start tonight is Dr. Rayford, will you give us the update? And then I think we want to ease in, and everybody has kids, families, and even people planning to have families, and we know COVID is affecting everybody. So is there any new intelligence? And the reason that we're constantly talking about COVID is that I understand from your teaching is that the science, we're learning things every day. And if we cut this talk off, we could be losing some critical information to our community.
Yes.
And I must commend you on this right here. I was stopped by a lady at my church the other day, and she advised is that the only information that she was getting about COVID and the vaccine was coming from this show and from your knowledge of it. So would you kind of open us up and kind of bring us up to date?
Yeah. So as far as the update is, COVID is still a big deal in the community. There's still a high number of cases. We've settled from a peak to still high numbers. So we're reporting anywhere from up to 2,000 cases of new infections of coronavirus. Unfortunately, we're reporting a lot of deaths. And in January, we've actually surpassed 1,000 deaths that's been reported in the state of Mississippi. We were close to 1,000 in December, but we passed 1,000, and we still have more days to go in January. And what that represents is something that we've seen even with the summer surges, is that there's a lag of a few weeks between the surge in cases and the surge in hospitalizations, and unfortunately the surge in deaths. So it's very much still a big deal. Vaccines are being given. Our current vaccine system has several challenges. Groups aren't getting the vaccine at an equal rate. There's some disparities in vaccine administration. So there's black-white disparity, there's rural-urban disparity, there's internet access disparities in vaccine administration. So that's something that is still ongoing. The state is still the primary distributor of vaccines. So we haven't got to that point where systems, particularly North Mississippi, is a vaccine provider. My hope is that we can become a vaccine provider. We know our service area, and we have an opportunity to better serve the service area because we've been taking care of these patients, in their rural areas with their limited internet access. So that's a hope of mine. In terms of other developments with coronavirus, we're learning more about the different variants. The ones that's been described in the United Kingdom, it's in the United States, and we haven't reported it in Mississippi, but it's close enough. So it's in Tennessee and Louisiana, and nothing is able to stay in Tennessee or Louisiana to keep from crossing the border. So we expect that variant to be here. The significance is to be determined. We don't know. We worry that it's going to lead to more surges, even with us delivering vaccines. The variant described in South Africa is one that's causing concern, although it has not been described kind of in our area. It's one where the worry is that there's less effectiveness to the neutralizing antibodies, so that raises the risk of people getting infections again if they've had it, people getting infections if they've been vaccinated. And so they're actually looking to see how well the vaccines work against that variant. And then when you think you know everything, there's another variant that's been described in Brazil that is been found in Minnesota. And so that's the one I don't know the most about, but I anticipate we'll learn more about that variant and what it means. And so what we have is, simply coronavirus, the strain is already here, is causing a lot of disease and hospitalizations and deaths. We have vaccines. The problem is getting vaccines into arms in an equitable way. And then we have the added worry of the different variants. So I think it's still really important to have regular sessions to get the information out. And to segue into our session today, I'm really thankful that we have Dr. Thomas Messado to really talk about the pediatric aspect. So I'm trained in pediatrics, but I don't see a lot of kids in my clinic. And I really haven't focused a lot on the pediatric aspect of coronavirus. Kids do get coronavirus. Kids do get sick. It's not a huge number, but kids do die of coronavirus. And so really talking about coronavirus in the pediatric population. We know that the virus doesn't stay in kids. So if in a family, if kids have the virus, that puts their older relatives at risk. And so it's not a vacuum. It's not a virus that happens in a vacuum. And so I'm thankful that Dr. Thomas Messado is able to kind of give us the pediatric perspective.
Well, thank you, and listen to you talk, and I'm hoping at some point we're going to have a lot better news, but we are obviously still in this fight, and there's obviously some dark days ahead, and we've got to continue this fight. So, Dr. Messado, pediatric critical care, exactly what is that, and how is it different from just general pediatrics?
So with pediatric critical care, we take care of those patients who have life-threatening illnesses. So those patients who have failure of major organ systems, respiratory failure, so if you need a lot of support to breathe, failure of the brain to work, so if you have any kind of altered mental status, heart failure, of course, or kidney failure, then those patients require closer monitoring and would require an ICU setting so that we can monitor their vitals, their electrolytes, their blood work closely so that we can prevent sudden onset of decompensation.
Wow. So how long have you been practicing this?
So I have been a pediatric intensivist for 3 years. I actually moved here to Tupelo 3 years ago.
Well, welcome.
Thank you. After completing my fellowship in Miami.
Okay. So have you had any experience with the kids in COVID?
Absolutely. So initially, in the pandemic, we were not seeing a lot of pediatric patients. I think that probably had to do with the fact that they were being infected, but their symptoms were very mild, and so those are the patients that stayed at home. But as the pandemic moved along, we started seeing trickling of these patients here and there. We have had pediatric COVID pneumonia with respiratory failure that required ICU. Those patients had comorbid illnesses, so asthma, obesity, chronic lung disease, cerebral palsy, we've seen those patients come in with respiratory failure. And we've had some pediatric patients who did not require ICU, who have been on the pediatric floor, who required a very, very minimal amount of oxygen, but oxygen nonetheless, and had prolonged days of fever. So we've kind of seen a wide range on the spectrum. We have also seen a complication of COVID in kids that was recently kind of isolated or identified in April of 2020 in UK called multi-system inflammatory syndrome associated with COVID in children. We have seen 2 of those patients here. They did require ICU. One of them had significant heart failure and had to be transferred. The other one had very mild heart failure and did very well here and actually was discharged home.
Wow, that is so interesting. Now, Dr. Rayford, before Dr. Messado came in, you were explaining the importance of what she's bringing to our area. I mean, he sold you really good. And so those of you out there listening, we're talking to Dr. Rayford Steele and Dr. Messado. We're getting into kids and COVID. And for those of you who don't know, please share this, share this, share this. This is critical information. And what more than to have our own specialists here talking about this. So what is the importance and what have we gained by having someone of her status in our area?
We are so fortunate to have Dr. Thomas Messado here because we're able to care for critically ill kids here. Previously, kids who were critically ill had to go to either Memphis, Birmingham, or Jackson. And so, it didn't matter where they came from. So if they were in Iuka and came here and they were critically ill, we would have to transport them to those places because we didn't have that level of expertise. And so having the ability to take care of critical kids here is a great asset for the pediatricians in the community. I know the pediatricians in the community are really, really supportive of having critical care here because it's not only is it disruptive for a family. So, having a critically ill child is a big deal anyway. Having a critically ill child 3 to 4 hours away from the family unit is another complication that, it just adds to the complexity. And so being able to take care of, and Dr. Thomas Messado actually, creating a program, and that's a huge feat of creating the program, getting the necessary training for the nurses, respiratory therapists, so that we can, deploy our resources to take care of our kids here. And so, it's a, incredible asset. And there's, we, not only that, she's a great resource. So if pediatricians need help, if I need help, she's there and available. My only wish is that we have a ton more pediatric critical care so that, there can be more breaks.
Hey, this is a start though, right?
Yeah, it's a start. It's hard being a pioneer.
It is
hard being a
but
pioneer.
it is worth it.
Yeah. Wow.
But it is worth it. We did add a second pediatric intensivist a few months ago, Dr. Joe Clacy. So he's here now, and we kind of alternate taking care of sick patients. So I do get a little break.
So when you think about kids and sickness, and I've raised 3 kids, I'll claim that. My wife claims she had some help. But when the flu season, and how is flu and COVID different in kids?
So that's a very good question, because that was what everybody was saying in the beginning of this pandemic. It's like, well, isn't it the flu? Are we all going to be okay even if we get it? And the answer to that now of course we have more answers to our questions. The answer is no. It is actually very different. So first things first, they are caused by completely different viruses. So the flu virus, the influenza or flu, is caused by influenza A and B viruses, versus COVID-19, which is caused by coronavirus, which is a coronaviridae group. And those viruses, because they're different, have different incubation periods. So an incubation period is the time between when the patient was exposed to when the patient first start having signs and symptoms. So for flu, that could be anywhere between 1 to 4 days, which is pretty short, as opposed to the coronavirus, where it could be anywhere from 1 to 14 days. So the incubation period for coronavirus is much longer. In terms of the signs and symptoms, you're right. They're pretty much similar: fever, cough, runny nose, myalgia, which is muscle pain, headaches, vomiting, diarrhea. They're pretty similar. But one big thing that's very, very different between flu and coronavirus is that coronavirus likes the lungs. They love to attack the lungs. And so acute pneumonia with acute respiratory failure, usually we don't see that in influenza patients unless they have some underlying issues, comorbidities like we talked about, asthma, chronic lung disease. But in coronavirus, even in healthy individuals, they're getting this significant pneumonia that's causing respiratory failure. In terms of the complications as well, they're a little different. So flu, generally, after 5 to 7 days, maybe even up to 14 days, symptoms go away, you feel better. With COVID-19, the symptoms kind of tend to lag, and we're seeing that more now in kids. Lots of fatigue, muscle pain, headache, chest pain can lag for a long period of time, and other complications including blood clots, which we usually do not see in influenza. We're seeing a lot in COVID-19. The other entity I mentioned earlier, MISC, we are now seeing associated with COVID, which basically is a revved up inflammatory process, we think secondary to infection or antibodies from COVID-19, that of course we would not see in influenza. That revs up the inflammation in the body, and the body starts to attack certain systems, including the heart, which is the biggest one. And a lot of these patients present with acute decompensated heart failure, some of them requiring ventilator support, some of them requiring ECMO support.
Wow, that's a lot of detailed information. So now you see why it's important that we keep these talks going and why it's important that you continue to share these videos. So Dr. Rayford, one thing that I'm wondering is, like, when our kids get a runny nose or maybe a cough, we say, hey, like the adults, the last result is to seek medical attention. And so is it more critical or more important that when the kids get these than to just go ahead and seek medical attention just to make sure?
I think so. I think with a highly prevalent coronavirus that's in our community at high levels, I think that any infection, because I think you will do things differently. So with a positive diagnosis of coronavirus, then you are contacting people who you had contact with. You know, you are changing your behaviors. The kids aren't necessarily you shouldn't send them to school. Please don't send a child to school if you think it could be possibly coronavirus. And any sniffle could be coronavirus.
That's
so
correct.
Don't send them to school. But I think it's important to seek attention now, even if what we do for a child with coronavirus in terms of there's not medicines that we give that can fight the virus, we just support them. So that means if there's a fever, we treat the fever. If there's a cough and they're above a certain age, we can treat the cough. And so I think it's important to ask yourself, could this be coronavirus? And answer if it's yes, get it checked out, because that cascade, there's a cascade of things that happen after a positive coronavirus. And there's also an unfortunate story that happens when there's a delay. And, you don't want people to feel horrible, but there are people who are dead because, that someone unsuspecting had coronavirus and they came into contact with someone who took it to someone who was at risk for dying. And so, there's so many stories and names of people who have died from coronavirus, and that question of where did it come from? It's a tough question. So now because I'm trained in pediatrics, and God bless my son. He has to be really sick before I even, seek.
Right.
God bless him.
Yes,
you know?
yes.
So even at that, if he sneezes more times than I'm used to, I'm like, oh goodness,
Right.
am I going to, are we going to test him? And so it's a lot different, but I know because it changes things. So whether or not I go to work or whether I try to work from home will depend on whether or not he has coronavirus. His classmates' parents will, whether they can work will depend, and God forbid, some important person, that, catches coronavirus from, so I would say if you suspect it's coronavirus, and we previously said, like my mom quoted, she said,
coronavirus until proven
it's
different.
coronavirus until proven different.
Okay.
And so, and with kids, it can really be, it can be really, really mild. It can be really mild. And so suspecting it, getting it evaluated. And then when kids, if they have it, and I may ask a question of Dr. Thomas Messado about, I know from pediatrics that you're used to seeing kids who feel bad and they're not, but then there are kids who feel bad and are critically ill. What are some of the things that families can kind of look at their, kid who doesn't feel good and say, well, you don't feel good and you look like you don't feel good, versus, oh, you look bad and we need to seek immediate attention, particularly, with coronavirus. And what are some of the signs of a critically ill child that parents or grandparents or anybody else can just recognize and say, no, this is different. This is more than just a child with a fever.
So your initial exposure to coronavirus, they are probably going to look okay. Cough, runny nose, they probably don't eat as much, but they're still playing in between fevers. You're able to break the fever. My concern is when that what those initial signs and symptoms are over, MISC, which is the big thing that we really worry about, will come on maybe around 4 to 6 weeks after your initial exposure to coronavirus. And so now with MISC, which is, of course, can cause heart failure, can cause your blood pressure to be low, there are a number of things that you have to look out for. So initially they may have fever, fever goes away. If fever comes back and they have persistent fever for 3, 4, 5 days, that should be a sign. If they start to have really red eyes, that should also be a sign. If they develop a rash, that should be a sign that they are not doing as well as you think they are, and they're probably going to get sicker. Usually children, if they don't drink a lot, they will not urinate as much, and that is a sign of dehydration. So if they're not peeing as much as they normally do, then that's a sign that they are sicker and you need to seek help. A lot of the MISC patients are presenting with more GI symptoms than respiratory symptoms. So vomiting and diarrhea. There has been a study that showed that vomiting and diarrhea actually is the number one sign and symptom for initial sign and symptom of heart failure in these MISC patients. Wow. So you may think, oh, they're having, vomiting or diarrhea is probably just a stomach bug. But if they're having persistent fever, if you know that they had coronavirus before, and this is 4 to 6 weeks later, red eyes, rash, just lying down, even when you break the fever, they still look very, very sleepy. Those are signs that you need to bring them to the hospital immediately. And just to go back to what you said earlier, that is one of the reasons why it's important, if your child has a runny nose, to check for COVID. Because that will give you an idea, that will tell you, okay, they had it. So if in a couple weeks I start to see these symptoms, don't wait, just go in. Some of these MISC patients are asymptomatic when they initially get COVID. So when they present with MISC, that's when we know, oh, you were exposed to COVID or had COVID 4 to 6 weeks ago.
Now, to break down MISC, would you just kind of break that down a little bit?
Absolutely. So MISC stands for Multi-System Inflammatory Syndrome associated with COVID in children.
I kind of knew that. I just wanted you to.
Absolutely. And that's, apart from those patients who have comorbid illnesses and COVID pneumonia, respiratory failure, MIS-C is the big thing that's unfortunately increasing morbidity and mortality in pediatric patients.
So, are you seeing more hospitalization with kids now?
Absolutely. So initially we were seeing maybe one or two here or there. We saw a number of neonates, I'll be honest, in the first week of life, and I was admitting those patients. They looked fantastic. No low oxygen levels, no breathing difficulties, no respiratory symptoms.
Wow.
They came in for something else, and we tested them maybe because mom was positive, and they turned out to be positive. And honestly, in the beginning of the pandemic, we didn't know the trajectory of the disease process in these patients. So I was admitting them, thinking maybe they're going to get worse on day 3. Maybe this is going to act like a typical viral illness. And initially, those patients did fine. And studies do show that those neonates, a lot of them do very, very well. It's the older children who have complications. And now we're seeing much more COVID-19 in children. A lot of them are incidental findings. So they come in for something else and they happen to be COVID positive. But a lot of them come in for symptoms related to COVID-19.
This is a two-part question for each one of you. The one for you is, can kids transmit the virus? And the other part is, talk about the school system just a little bit more.
Yeah.
And I know we getting into some touchy points here.
Yeah.
So I'd like to, first you, and then if you would just chime right in after that.
So children can transmit COVID-19. They do not transmit it as much as adults do. So coronavirus, I'm sure we've all seen a million pictures. We all know what coronavirus looks like. Those spike proteins on the outside is what actually causes an immune response in your body. And it attaches to these specific receptors called ACE2 receptors. And it is believed, based on the amount of studies that have been done in the last year, that children actually don't have as much of those ACE2 receptors in their nose, mouth, and throat as adults do. So they don't carry as much virus in the nose, throat, and mouth as adults do. Now, other studies have suggested that they carry the same amount of viral load in the nose, throat, and mouth, but they carry that level for a shorter period of time. So their chances of spreading it is much shorter compared to adults.
One other thing before we go to the schools. You talked about the photos that's on the news. Now, I'm finna ask a question that may sound very ignorant, but somebody like me, just a common Joe Blow in the public. I had no idea that the pictures they're showing on the news, that's actually a picture of the coronavirus.
Absolutely. That is exactly what it looks like under a microscope.
That's scary.
Yes.
I just had to get that out of there. I hope somebody else thought about that too, so they won't admit it.
Yeah, you gave me a little bit more time to talk about the controversial. I mean, what a national, international controversy of schools. And, I will tell you that in July, I had concerns. There was uncertainty about schools and whether or not my son would return to school and what things were what it would look like, how much risk would he have. And so, and I talked to many parents who, worried about that. And I want to start by saying that, parents who have made decisions in the best interest of their children, you did what was right. Some sent kids to school, some kept kids at home. And so, because there's been a lot of shaming one way or the other. How could you let your kid go to school? How could you keep your kid away? We know that school plays a really important role for our kids. School becomes, a safety net for many of our kids, and that's definitely notable in Mississippi. That schools are a safety net, working with, public schools, addressing childhood hunger and, child abuse. And so, schools play a really, really important role in the normal development of a child. So the decision to go back to school, I don't envy people on the school boards, Mr. Wheeler. I don't envy those decisions. I know in some places there's some really heated debates. So many of my friends in the Boston area where the schools have been virtual, there's a lot of parents, pediatricians who are now advocating for them to go back to school because of the significant benefit. And we've learned about the virus. So kids can transmit the virus. We know that their age, so younger kids less so than older kids. And we, looking back at our information from Mississippi, I think it's a case study in, return to school. So we started school into a summer peak. So in the summer peak, school started. They were delayed, but we were very much in the summer peak. So we started school with measures in place. And what we were able to see was, with the measures that were in place, that the actual rates of coronavirus in the community actually went down. And they kept going down until October 1st, September 30th, things happened. But October 1st, it seems that things kept going down. So we started in a peak, but the cases started coming down until they started going back up. And there's some different reasons in terms of pandemic fatigue, people socializing more. But we were able to show that schools were able to safely do it. And then researchers in Jackson, and so one opportunity where Mississippi leading the way, researchers in Jackson actually studied the likelihood of a child getting coronavirus in the school setting versus the non-school setting. And they've actually published that data, and it's informing CDC recognitions to show that with precautions, masking and distance and changes to lunch and things like that, that kids are not likely to get coronavirus in the school when they're doing those things. Now, if you're not doing those things, that risk is high. But their chance of getting coronavirus is lower. And that it was really interesting. They had kids who were diagnosed with coronavirus, and they called the parents and asked them, well, what were they doing in the weeks preceding? And found out that most kids who got coronavirus had gone to a wedding or a sporting event or out or was exposed to some family contact with coronavirus and not to school. And so there's even today, there was a news report about schools who take precautions, that the risk, and so I anticipate more schools are going to go back to the in-person option and, highlight for, celebrate Mississippi when we're doing it good, we're doing things good, learning from our experiences in Mississippi. And I'll finish by saying there's a humongous caveat. When there's high levels of coronavirus in the community, there's going to be high levels of coronavirus infections in kids. And so as we are hopefully coming out of our Thanksgiving to January 1st peak, we've also seen record numbers of pediatric coronavirus infections, definitely nationally. The data is harder for me to see kind of in the state and locally in terms, but nationally, a couple of weeks ago, 250,000 pediatric patients were diagnosed with coronavirus. So as it stands, 2.6 million kids have been diagnosed with coronavirus. It may actually be more kids have been infected, but 2.6 million diagnosed compared to 25 plus million people. So about 10 to 12% of the coronavirus infections are occurring in pediatrics. And so those are kids 18 and younger.
And of those patients, about 2%, 1.8 to 2% are hospitalized. And of those patients, less than 1% die. So they do die, but they're not dying nowhere near to the rate that adults die. So usually with adult patients, they have comorbidities. We talked about hypertension, diabetes, other things that would complicate their illness, and kids usually don't. And kids generally have a robust immune system. Their thymus is working real good. And so they get infected, but they don't get as sick as adult patients. Just to give you some numbers in Mississippi for children, as of December 2020, we had about 32,000 pediatric COVID-19 positive patients, not patients, positive cases in Mississippi. Just about 53% of that was between the ages of 11 and 15. So more than half of them were older kids, and only about 1,700 were less than 3 years old. So that kind of gives you an idea.
Interesting. So for those of you that may be just joining us, we're asking you to continue to share this video because we're still talking to Dr. Rayford and Dr. Thomas Messado, but we're getting into our kids and pediatrics, and Dr. Thomas Messado is new to us, and she's a specialist in critical care, which is just awesome. So we're going to ask you to continue to share this video. And Dr. Thomas Messado, they telling me it's time to get out of here because you got to go.
He's going to edit this out.
Just ask a question.
Okay. Could you, two things. Pediatric patients that when they recover, have you had anything reported back to you about their sense of taste or even weight loss because they're not tasting anything? And then the other question was, and our next series is on, and I don't know, with dementia, not dementia, but some psychiatric, I guess, reactions to COVID. Have you experienced that with pediatric, with your patients?
So not in Mississippi. I have not. I'm yet to.
He's going to phrase that question for you.
Oh,
then
gotcha.
Then we're going to edit that in.
Okay.
See if I can remember that.
So in other words,
Patients
we've had some contact with adults that have had COVID, and there's been some psychological hallucinations. There's been things that have gone on even 3 to 4 weeks after they have been negative for COVID. Is that the same in kids?
So in Mississippi, we have not seen that.
Okay.
Of course, time will tell. But there have been case reports in other states where pediatric patients suffer from depression, acute psychosis, and other acute psychiatric illnesses associated with COVID-19. Of course, some people are saying, well, is it more associated with the pandemic per se? Are these pediatric patients that were not in school, weren't getting that social interaction that they're used to? Or was it really and truly from the infection from COVID-19? That question is yet still to be answered, but we think there is an association with the actual disease infection and these patients presenting later down on the road with some kind of psychiatric concerns.
Okay. So obviously we're going to be coming back again because this thing is constantly going. So in closing, what's just on your mind and heart that you know that the community needs to know about pediatrics and critical care?
I know that it's been a year and everybody's frustrated and everybody is tired. And it is very hard to see the light at the end of the tunnel. I know when vaccines came out, even for me, I was like, okay, I think we're almost there. And then, of course, as we would expect any other virus to mutate, new variants and new strains are coming out, and that has, the community concerned, of course, appropriately so. But do not lose hope. Continue to mask, continue to social distance, continue to wash your hands. I know it's very, very hard and we kind of want to just loosen up a little bit and take it easy, but now is not the time. I think we've generally been doing a very good job in the last few months of masking and social distancing, but keep up the good work. It is working. Our hospitalizations are down. And so, I think with time we will get there.
Well, thank you. So, Dr. Rayford, now in the experience in the past couple of weeks, and I'm going to ask you to close with this too, as far as the vaccines, as far as what you're seeing and just what's on your mind and heart to close. But we have a lot of people out there now, some that hadn't even taken the vaccine that's running, and they're telling people in the community, take the vaccine, then some said, don't take the vaccine, the vaccine. And I guess that me in my mind, just trying to be open and honest here, is that confuses me. when
Yeah.
people are telling me to do something and they haven't read the data.
Yeah.
They don't have the medical background.
Yeah.
So can you, as a physician, just kind of iterate that in your closing about taking the vaccine and you actually studying the data on these vaccines?
Yeah, I like to talk about the vaccines, and particularly in light of pediatric patients. So right now, the youngest a person can be to get a vaccine is 16. And so getting vaccinated also protects our children. So I said that high levels of coronavirus in the community will affect our kids. And if we have more pediatric infections, we're probably going to have more of the severe complications. So, getting vaccinated is good for protecting you, but it's also protective for, right now, our kids. And the public health measures, the masking, the distance, the small gatherings, the rethinking events. So, going to a crowded basketball game is not a great idea. So, rethinking those things is really important for protecting our kids. And for adults who are able to get vaccinated, getting vaccinated also protects our kids. And so the vaccines are a really important thing for getting us to that point where there's enough immunity in the population so that we can start reestablishing our normals, getting our kids back to school, and that's a big deal, and also get us to the point where we can just sit back and see the effects of the pandemic. There's still things that we're not aware of, but we're focusing on fighting the pandemic, rightly so. And if we can get the pandemic fight on autopilot, and that's with vaccines. So as more comes, more goes into arms, and working on distribution of vaccines, making sure, I hope that data comes out to recommend vaccines for kids younger than 16. My hope is that data will come out and we can add kids to the group who needs vaccines. But right now, less than 16, they're relying on us adults to protect them, by encouraging them to follow those social. We know that when you do it, the rates of transmissions are actually really low. So, that is something to be hopeful for, that we are able to get our kids in school. We're able to keep them as safe as we can by doing those public health measures. And I go back to, if you are eligible for the vaccine, I highly recommend it. I give it my highest recommendation. And I tell people that I looked at the data for myself and felt really confident in the vaccine, and not only giving it to me, but wanting my parents and my grandmother to have the vaccine, and wanting everybody who's eligible in my life to have it. And so, that's the highest recommendation that I can probably give, other than me getting the vaccine and putting it in your arm myself.
Right.
And I'm willing to learn. and I'm willing to learn, but I think that it's a very important tool to add to what we've been doing, and it protects more than just me. I'm thankful for the protection from the vaccine, but I'm also thankful that it's protecting the people around me, particularly my son, who can't get the vaccine.
And I'm going to remind people also, you and Dr. Eric Lewis were featured in the Daily Journal this past Sunday. And those of you who haven't seen that article, it is just awesome. And one thing I appreciate about that article is that it's African-American doctors, professionals in our community that is just being open and honest, because they care about our community and want to see us strive and do better, and we and our loved ones and all. Now, Dr. Thomas Messado, have you had the vaccine?
I have had both of my vaccines. And just to tag on to what Dr. Rayford said, a lot of people are wondering, the vaccine came out in a short period of time, is it safe? It is safe. So vaccine trials go through many different phases. Preclinical is the longest one, that's because, people have to decide, okay, genetically, what does the virus look like? And because we came together as a global village, it was very easy and took a shorter time than normal to identify what this virus looks like genetically, to map it out, and so that we could identify, okay, the spike protein is what the issue is, and we're going to make an mRNA vaccine against this virus. mRNA vaccines are not new. This has been around for the last 30 years. SARS, when SARS came out in 2003, when MERS came out in 2012, they looked at mRNA vaccines for these particular diseases, and so it is not new. And when I got my first vaccine, I won't lie, there was just a little bit of, am I gonna be okay? And I was completely fine. People have been having more side effects to the second dose. I did not personally have any side effects to my second dose, but even with the mild side effects that you're going to have, it is worth it in the end to not be in the ICU on a ventilator because of COVID pneumonia. So I think that's important. Pfizer and Moderna are now enrolling children between the ages of 12 to 16 for
New
vaccine,
information?
Yes, for vaccine trials. So we should have that information soon.
Awesome.
Yeah.
So again, Robert Hall, Chairman, Project-elect, and we're a conduit to put that information out. We want to give all the information we can to the community. And I'm just humble, Dr. Thomas Messado. This first time we met, but we're humble and just glad to have you in our community. And thank you for giving the extra time that I know you work, Dr. Rayford works, but you give your extra time to come and to share this with the community.
Absolutely.
And Dr. Rayford, as always, thank you. And we're looking to come back next week or so with new information. Share. Again, as always, we thank Mr. Kenneth Wheeler, North Mississippi Medical Center, for allowing us to use this facility. The man behind the camera that makes it all work, Maurice Schumpert, Secretary of Project-elect. And I must say that Kenneth Wheeler is now the co-chair of Project-elect. So until next time, we'll see you soon. God bless.